The oblique lateral interbody fusion, the OLIF, is you're sort of splitting the difference between the ALIF and the LLIF.
Direct lateral surgery, while it beautifully removes potential complication from all the anterior spine elements, viscera, it's conducted through the psoas muscle. So that trans-psoas approach brings into play the potential for neurologic complications.
By having the patient in a lateral position, it allows the abdominal contents to sort of fall out of the way, so it makes the exposure easier. We're more posterior or lateral to the vascular structures, so we don't have to mobilize them as aggressively as you would with a traditional ALIF approach.
If you get people back to work quickly, that's a huge deal. So from a medical, surgical, and economic standpoint, this has huge advantages. If you design an operation that only 3% of surgeons can do, that's a limited thing. But if you can design an operation that the average surgeon can do really well, then the population can benefit. So that's what we're trying to do.
Thank you everyone for joining us for this educational event where we're going to showcase the innovative OLIF approach as well as the science behind SPIRA technology for anterior lumbar pathologies. My name is Robin Young. I'm the publisher of Orthopedics This Week. And I want to begin by making a note that the SPIRA technology is one of the winners of our 2020 Best Technology in Spine Award. The SPIRA is a unique design. I think when you look at it, you immediately can tell this is not like other lumbar implants, but that design is specifically why it won the Best Technology Award. And what's really special is this evening, we have an outstanding faculty that will share some of their hands-on experience using the SPIRA technology, and really, particularly when coupled with the OLIF approach, really is a really interesting approach to dealing with, again, anterior lumbar pathology. Kicking us off this evening is one of my dear friends, John Williams. He's an orthopedic surgeon at Spine One in Fort Wayne, Indiana. He has over 30 years of experience in medicine and a member of the American Academy of Orthopedic Surgeons. But really, we could not do any better than starting off with John Williams. He's going to give a great overview of the OLIF approach with SPIRA. And also joining John in giving a presentation is Jeffrey Mcconnell. Dr. Mcconnell is with the Pennsylvania Spine and Scoliosis Institute. I've had a chance to hear his presentation. It's an outstanding description of the OLIF approach with SPIRA. I think you're going to really enjoy his talk. He'll be coming up next. And joining those two in the Q&A section will be John Pelosa, another dear friend. He's with the Stedman Clinic in Vail, Colorado. I'm sure many of you have had a chance to hear him before on the podium, but he is, of course, one of the internationally recognized orthopedic spine surgeons, a true pioneer in minimally invasive surgical technologies. And in the Q&A, make sure you ask questions. John is there, and he has a lot of experience with OLIF and using SPIRA as well. And also, during the Q&A, we are really fortunate to have Dr. Naman Abdullah, who comes to us from the University of Miami Hospitals. He's a cardiovascular thoracic surgeon, and he's one of the very few surgeons to do anterior retroperitoneal exposure of the vertebral discs. He is going to add a lot to our Q&A. He brings to us more than 20 years of experience in this area, and I think it really rounds out a very rich program. Again, we're going to be reviewing the OLIF approach using SPIRA, which won the Best Technology in Spine Award last year. And I think you'll find as you listen to the presentations that it's really an important new innovation in spine care. So with that, it is my pleasure to turn the program over to my good friend, John Williams. And John, please take our meeting. Thank you.
Thank you, Robin. And Robin, I can't tell you what a privilege it is to join with these other gentlemen on this platform. I can just say how much we as an orthopedic community appreciate what you do to establish and maintain this platform for us to disseminate and discuss ideas. So it really is a pleasure. Good evening, everyone listening. We're going to talk tonight about looking at anterior column reconstructive options through a minimally invasive approach. And tonight we're going to talk about doing that anterior to the psoas in a procedure that is also commonly referred to as an oblique lumbar inner body fusion. And the three gentlemen with me tonight, Dr. Abdullah, Dr. Pelosa, Dr. Mcconnell, are all gifted surgeons, and I can't wait to hear their responses to your questions. And so let's start by just throwing a poll question out. Please, participants, jump in and ask questions or make comments that we can all try to address and work collegially to learn more about this approach. So poll question number one, which anterior column lumbar approach are you most commonly using at the present? And if I could get all the participants to weigh in on this, a direct lateral approach or trans-psoas approach, a traditional supine ALIF approach, the oblique lumbar inner body fusion. If you're already doing it, please note that. Or are you doing posterior surgery only right now, and you're looking to add another tool to your toolbox by being here tonight? And then the second poll question, why are you using OLIF or considering using OLIF in your practice? What is it exactly that you want to accomplish? And is it to be able to get to L5-S1, or is it to avoid the lumbar plexus, as many of us have found to be an issue when working in the trans-psoas space? So I'm gonna weigh in here as well. All right, let's look at our results here before we jump into the didactic portion. So it looks like the vast majority of us this evening are still using the traditional supine ALIF, with about a quarter of the folks watching already using the oblique lumbar inner body fusion. There's still about 10% of people listening are using trans-psoas or direct lateral approaches to the anterior lumbar spine. And then a fifth of us, almost 20%, are still doing posterior only surgery. On question number two, I think this is interesting. So both A and B, which I think is really what drove my evolution into this space, but truly to avoid the lumbar plexus injury and also to achieve access at L5-S1 in a minimally invasive way, are two very good reasons to move in this direction. We're going to speak for the next few minutes about addressing the anterior column of the lumbar spine with a minimally invasive approach. So in this situation, this oblique approach, we're going to be in the interval between the psoas muscle and the great vessels of the spine. And today we're going to limit this talk to working from L2 down to S1. And we'll divide L2 through L5 into a separate space or category from L5-S1. So what are some of the upsides of an oblique lumbar inner body fusion? Well, one advantage is we remove the lumbar plexus out of harm's way when we move anterior to the psoas muscle. And because of that, we don't need to use neuromonitoring. Now, when neuromonitoring is no longer necessary, the anesthesiologist can apply muscle relaxation, and that paralysis allows us to move or manipulate the abdominal cavity more, making access to the spine a little easier than if they're using TIVA, where if neuromonitoring is necessary to monitor the lumbar plexus, as in direct lateral surgery, the abdominal wall can be tight and can keep us from getting smooth and efficient access to the inner body space. Working in this oblique space, we can avoid injuring the paraspinous musculature. So no longer do we need to strip off the paraspinous musculature during the posterior instrumentation portion of the procedure, but we can use a percutaneous lumbar
fixation techniques that follow oblique lumbar interbody fusion surgery. The iliac crest, which tends to be a real problem at L4-5 and certainly at L5-S1 when working in a direct lateral position, is no longer an issue because we can move anterior to the ilium. Our end plate preparation I have found to be significantly improved from direct lateral surgery because of our access and visualization. So we get outstanding end plate prep and therefore better fusion rates. Because we can visualize the disc better, we can actually work back into the spinal canal, working all the way back through the posterior annulus, back to the posterior longitudinal ligament. We can certainly, achieving multiple levels through a single skin incision is certainly possible. We have a shorter length of stays because of the less invasive nature of this procedure, less damage to the abdominal wall. So our length of stay in the hospital has come down. Our intraoperative time can also diminish because with this oblique approach to the interbody space, we can do single position surgery. That option is available to you, whereas single position surgery is not when we do traditional anterior interbody fusions. And that's with traditional supine A-lift surgery, you're forced to reposition the patient to apply your posterior instrumentation. And then this idea or concept of indirect decompression is wholly open to you because you're able to get so far posterior into the disc space and get good posterior interbody distraction. Some of the downsides to an oblique approach are just really the learning curve. Moving through the process of learning this dissection to do it safely can seem intimidating. And that's what we're here today to talk a little bit about and hopefully make that a smooth transition for you in your practice. There is the potential for vascular injury. As we move anterior to the psoas muscle, the vasculature that exists anterior to the spine comes into play. And so we're going to talk about some techniques to avoid injury to this. Certainly the potential for injury to urologic structures and the peritoneum or the peritoneal context come into play because you're mobilizing these tissues out of harm's way in order to work anterior to the psoas muscle. But I'd like you to look just for a moment at a pair of very compelling CT scans. Now these are CT scans of the fresh frozen cadaver, and I'm going to draw your attention first to the image on the left with the red highlighting. This is a cadaveric specimen where the specimen is supine on the table, and you can see, if you can follow my cursor here around the red area, that the peritoneum is pushed down intimately against the spine in a way that this has to be mobilized using retractors to get to the spine. But if you now track with your eyes to the CT image on the right, this image, the specimen is placed in the lateral decubitus position, and you can see that gravity pulls the peritoneal contents out of the way of the surgeon, really giving you outstanding access between the ilium and the peritoneal contents. And this is the interval we're going to be looking for right here between the psoas muscle and the peritoneum. And you can see how moving the patient into the lateral decubitus position really facilitates getting into the spine safely. We mentioned the vascular structures that can come into play in this operation. Let's look specifically at L5-S1 for a moment. And I'm going to talk to you about some favorable anatomy and then some unfavorable anatomy, both of which can be addressed with this. But you want to be aware of this before surgery. And before you move into the more challenging anatomy, you want to get 15 or 20 of these cases under your belt. So in a easier way to start at L5-S1 is this MR image on the left. This is an axial image at L5-S1, and you can see, if you follow my cursor here, there's a significant amount of space between the left common iliac vein and left common femoral artery, and the right common iliac vein and right common femoral artery, which is already bifurcated here. So this space right here is the space that you have to get into and work surgically. Now, if you track with your eyes to the axial MR image on the right, you'll see, if you look right here, this is the S1 pedicle. So you're already distal to the L5 S1 disc. And look how midline the left common iliac vein exists right here. So in this case, in order to get into the L5 S1 disc space, you're going to have to identify and mobilize this vein out of harm's way. And so this should not be one of your first 12 or 20 cases, because this is something where either you and your access surgeon are going to have to make the effort to mobilize that vein out of harm's way. It's doable, but it requires thought and some practice at this procedure. Here is another pair of images, and this is why pre-operative planning is so critical with this operation, but it just prepares you for what you're going to find intraoperatively. Please look to the left. This is an axial MR image, again, L5S1, and look at the left common iliac vein. It shows a bright signal indicative of adipose, where there's a solid fat layer between the spine and that vein. And here, you know that vein is going to be easily mobilizable because of this imaging. You also see that the vein itself is rounded. Now let's track with your eyes to this MR image on the right and look at the difference between this common iliac vein compared to the one on the left. In this case, you see there's a sharp corner indicating that vein may be under tension. That indicates that due to the long-standing inflammation in this disc, there's been some sort of response where that vein is adherent to the anterior annulus. So that vein is going to have to be mobilized carefully to avoid injury if you're going to get into this disc space. The other thing you see that indicates to you there's going to be some trouble is that there's no adipose or no fat between the spine and the vein, again indicating that there may be adherence between that vein and the underlying spine. So it's very doable, but in this case, you're going to take your endokitner, you're going to get right on the disc space that's visible to you, and then just gently roll that Kittner against the annulus, watching this vein and mobilizing it laterally out of harm's way. And typically, the best way to begin this is begin down on the sacrum, then work up onto the disc space and mobilize this before you place your vascular retractor blade under that vein. So let's talk about different vascular patterns that you are going to encounter in the spine, because this is what we want to accomplish. You see on the left images, you see how there's severe disc space collapse, and that disc space collapse has been restored with a obliquely placed interbody cage, restoring this foramen back here. And then this plate has been placed anterior to the cage. So in this case, we've done a standalone L5S1 OLIF to restore that neuroforaminal space. In this case, this is what I'm looking at the MRI image in the office and before the case begins in the operating room. And look with you, if you will, watch this scout line go down across the L5S1 disc. And at the level of that L5S1 disc, when you track over here with your eyes to the left-sided axial image, you see that there's a wide space between the left iliac and femoral vessels compared to the right iliac and femoral vessels. You just got a great space here to look and get into L5S1. Now let's look at this next patient. Similar pathology to the last one. You see at L5S1, there's a complete collapse of the L5 disc space. So we want to get in there and restore that, to add lordosis, restore sagittal balance, do a good posterior decompression of the spinal canal, and place our interbody implant to maintain that indirect decompression. And we'll do that by placing this cage followed by a plate. And in this case, there's also a small spondylolisthesis at L4-5. So we're also going to place a inner body cage at L4-5. But look at the vasculature in this case. And look how different it is. So at L4-5, you see there's a nice window between the aorta and the psoas, so no trouble getting into L4-5. But when you go down to L5-S1, you see that this left common iliac vein is still in the midline. So let that video run here a couple more times so you can look at it. When the scout view on the right gets to L5-S1, track with your eyes over here and look right in the midline of the lumbar spine. And you see that vessel is slow to move, slow to migrate to the lateral side. So in this case, you've got to get under that. Let's see if I can pause this video for you. So in this case, here you see, I've just kind of paused it right at the lower disc level at L5-S1. You see that you're going to have to get under this vein, which has that sharp angle, and use your Kittner to mobilize this vein, which appears to be adherent to the anterior spine, mobilizing that vein off to the side so you can get your vascular retractor underneath it in order to access this space and get this implant in that you see on the left. In this case, we also used a plate just to make sure, at L5-S1, even from an oblique approach, it's a little bit more like a traditional ALIF. You're taking down the entire anterior longitudinal ligament. And so typically, once the implant is placed, you want to ensure that you do something to make sure that that cage can't move, either with a low profile device, or my preference is to place an anterior plate across that disc space to ensure that L5-S1 implant cannot come back out into the bifurcation of the great vessels. I'm going to show you another example of a low bifurcation and what you can do with this procedure. So in this case, you see that there's, if you look at the preoperative pathology on this right X-ray image, you see that there's severe disc space collapse. There's a retrolisthesis that moves the inferior posterior corner of L5 just straight back into the foramen. And so you see bad bony foraminal stenosis. And in order to restore this foramen, you've got to get into this space with an implant that allows you good posterior distraction. And that's what this SPIRA implant allows you to do. But in this case, you notice I did not place a plate on this, and I'm going to show you why. So once again, just to show why and what a low bifurcation looks like on your preoperative planning. Here you can see the left common iliac vein, the right common iliac vein. And if you look between them, follow my cursor, you can still see tissue where this vessel has just bifurcated. And that's right here at the inferior, if you look on the scout view to the right, that's right at the inferior aspect of the L5 vertebral body. And now watch as we walk through this MRI. So here is the superior aspect of the L5-S1 disc. You can see that the left common iliac vein is still across the midline. And here at the superior end plate of S1, the inferior aspect of the L5-S1 disc, you still see that left common iliac vein remains periusly close to the midline, where you're going to have to get underneath this vessel by using your Kittner. Just bluntly mobilize that vessel off of that disc space to move it out of harm's way. But still doable. But in this case, because of the low bifurcation, I elected not to put a cage, I elected not to put a plate here, because what happens actually is when you take this collapsed space, you open it with your implant, you actually move the L5 vertebra up even higher under the bifurcation. And so in this case, I felt like an anterior plate could not be safely placed. This was a great case to do with a single position approach, because once this cage was in place, we could walk around to the posterior aspect of the patient while she's still in the lateral decubitus position and place bilateral screws, bilateral rods to lock that cage into place, put a little compression on it in the back, knowing then that cage is safely placed without applying an anterior plate. It's say one of the other advantages of this implant, though, the roughened surface of this SPIRA implant really does give you outstanding fixation against bone, particularly in this situation where you have to work hard to restore that space with distraction techniques. And then once the cage is placed, you really get good solid compression of L5, compressing that implant onto the superior end plate of S1. Let's talk a little bit about positioning. Positioning is very similar to direct lateral surgery. The patient goes to sleep and is intubated while they're supine, and then they're repositioned in the lateral decubitus position, the right lateral decubitus position, so the left flank is up. In this case, this is a 240-pound farmer, so a large individual. You can see he's had previous surgery, previous decompressive surgery. So this is a case that we don't want to do open T-lifts or have to go back through the spinal canal where there's a post-procedural scar tissue. So this is a great case to do the oblique lumbar interbody technique, indirect decompression, and posterior percutaneous screw placement with the patient maintained in a single position. So for the surgeons out there that have a significant experience with direct lateral surgery, you see this looks very similar to that. A couple of simple differences, I'm going to point them out. With direct lateral surgery, we tend to flex the hips and flex the knees to relax the psoas muscle. But with oblique surgery, we want to extend the hips and extend the knees for several reasons. One is it puts the psoas under tension and moves it posterior, moving it out of our surgical field. The lumbar plexus is not at risk here. We're working anterior to the psoas, so we don't worry about having it under tension. The other thing that's critical, if the hips or knees are flexed at all, when you work anterior and you're trying to get into that L5S1 disc space, that left hip or left thigh is going to fall into your field and is going to impede your hands for working directly into that L5S1 disc space. So I can't tell you how critical this portion of the positioning is, having the hips and knees fully extended. The other thing I'll point out that's a little different than direct lateral surgery is normally when you're working at L4-5 and up, you place this middle taping compound right over the greater trochanter. But here, to make sure that we have access to L5S1, we want to put this taping position, the central taping component, over the mid thigh. So first taping component is just below the axilla of the chest cavity. Second taping or middle taping component is at mid thigh. And then there's a third taping component stabilizing the legs distal to the knee, distal to the fibular head, so that the perineal nerve is well taken care of. If you notice on the left, the right image, this shows mark the skin, marking the anterior superior iliac spine and the iliac crest. And you'll notice that we want to work 2 finger breaths anterior to the anterior superior iliac crest to avoid injury of the sensory nerves that are in this region. The ilioinguinal nerve typically is running right along the inguinal ligament. That is not going to be in harm's way to an extent, but the iliohypogastric sensory nerve can come into play if you make your incision and dissection down onto the abdominal wall too lateral. So we want to remain at L5S1, 2 finger breaths anterior to the ASIS. The other thing, you'll notice a skin mark right here that's right in line with the disc that's been marked on the skin. We always want to mark the skin with the exact target disc we're looking for, because as we work doing our dissection, we're going to keep our eye on that mark to get to the specific disc we're looking for. So mark your target discs with the anterior disc, posterior disc, and the trajectory of that disc using your lateral fluoroscopic image prior to prepping and draping. And then straight in line with that disc, you see the second skin mark. That's going to be our fascial incision. So this is a brief, just 60-second video. It's sped up a little bit, so it looks a little Keystone Cop-ish, but just showing you the taping of the patient that we just looked at. So once the taping's down, bear huggers are in place, patient's covered up with blankets, we first get an AP fluoroscopic view, make sure that our rotation is neutral. Then a lateral fluoroscopic view is used to mark the skin of the trajectory discs we want. It's at this point we make sure all bony prominences are padded, and we make sure that we like our images to ensure that there are no wires, Foley catheters, monitoring wires anywhere in our fluoroscopic images in both the AP and lateral. So it really, one of the great advantages of the oblique lumbar interbody fusion over a traditional supine ALIF is it's so easy to access fluoro, and the benefit of fluoro in this case is unimaginable. It really allows you to get aggressive with a lateral fluoroscopic image, working back with your Kersons and curettes to get back into the spinal canal. So you can do that under direct vision, but you have the luxury of fluoroscopic assistance to really walk back and be aggressive with your posterior decompression. And in this case, you just see that I'm pointing out this patient has a relatively steep L5S1 disc. So we need to take that fascial incision into account. It's going to be very low on the patient's abdomen. So let's talk a little bit about dissection. This is a series of Netter-like images showing us how to safely develop the retroperitoneal space and expose the anterior lumbar spine just anterior to the psoas. So with your eye, let's look to the far left image. Once you've made your skin incision and you know exactly where you want to make your fascial incision, which is you're going to put your finger right at the disc space that you want to get to, and you're going to do that with your eyes looking at that trajectory disc mark on the patient's lateral flank that you've already marked. Just gently with a back and forth motion, work your finger bluntly through the first external abdominal oblique, internal abdominal oblique, and transversus abdominis. All of this dissection is, of course, lateral to the rectus. Here's your rectus muscle. My cursor is right on the rectus. So our dissection is lateral to the rectus. And once we feel our finger give through the abdominal wall, you're in the retroperitoneal space. Now that omental fat here is your friend, and you're going to stay outside the peritoneum. Turn your hand as soon as your finger pops through the abdominal wall. Turn your hand with the palm towards the ceiling, windshield wipering your finger back and forth under the abdominal wall and walking it right back to the posterior abdominal wall. At L5S1, the first thing you're going to feel is the iliac crest and then the iliacus muscle represented here. And now with your finger, once you're back on that posterior wall, now you're going to turn your palm to the floor, palm down. That's the third image that you're looking at here, and sweep the peritoneum off the psoas muscle. And it's a gentle, usually you have two fingers in there. You can just bicycle your fingers right along the psoas muscle, moving the peritoneum and the peritoneal contents out of the way. Because you're in the lateral decubitus position, gravity is your friend here. It really helps pull the peritoneum out of the way until you palpate. At L5S1, you're going to palpate a pulse, which is the left common femoral artery, or above L5, you're going to palpate the pulse of the aorta. And then just windshield wiper, sweep your finger back and forth, looking for the ridge of the disc that you're seeking, the target disc. And then I'm going to show you how to walk in there with a lighted guided retractor to establish your position. So here's just a brief video walking through that, the abdominal wall dissection that we just talked about. And this is the, so in this case, we're approaching L5S1, and we're also going to do L4-5 through this same skin incision. Of those two discs, you're going to use two different muscular dissections, but a single skin incision for first L5S1, then L4-5. So in this case, you open the abdominal fascia in line with the skin incision. You're going to gently, with your index finger, advance through the abdominal wall. You're going to feel that muscle give way, and once that resistance to the abdominal wall ends, then you're going to windshield wiper your finger back and forth all the way around this muscular opening, starting with your palm towards the ceiling, working your finger posteriorly until you palpate the iliacus muscle, and then move your palm towards the floor. And you're going to palpate, if at L5S1, you're going to palpate the left common femoral artery, come over the top of that artery, and palpate the sacral promontory. So how do we see this now? And we've talked about the approach and the dissection. How do we see this? Camber has developed a system which really works beautifully, starting from the sacrum all the way up to T12, that allows you to safely maintain any of the soft tissue in harm's way out of harm's way. So at L5, we're going to start at L5S1, and then we'll talk about L5 and cephalad. At L5S1, typically, you're going to use a 3 retractor technique, with placing your first retractor here to maintain the left common femoral artery, left common iliac vein out of harm's way. The second retractor blade you'll place is a Hohmann-tipped blade, which will go on the far side of the spine, and you'll develop this using a Kittner elevator and the tip of this blade in somewhat of a walking chopstick fashion to safely tuck this Hohmann-style blade into a soft tissue pocket on the far side of the spine. And finally, after you identify and ligate the middle sacral vessels, then you'll place and you mobilize those with a Kittner elevator. You'll place your middle bifurcation blade, which is a gold blade, just keeping the bifurcation out of harm's way before you begin your discectomy. So let's look at what the variant access system looks like from Camber. It's all predicated on these mobile mini arms, and this allows you to create an access system or a retractor system that's unique every time for each patient's unique anatomical needs. You have multiple blade lengths and 3 different blade types. So 2 of the blades are your traditional vascular retractor blades with a lip on them, and the third type is a Hohmann-tipped blade for use between the spine and the great vessels. Once you've performed your blunt dissection down onto the spine, the first retractor that goes in is this blue bladed retractor, and it's used to move the left common iliac vein, left common femoral artery out of harm's way. You're going to pin the L5S1 blade distally. Always pin distally at L5S1, because it's at that point your vessels are moving out of your field towards the left lower extremity. You're going to take a Kittner along with this black blade, develop a soft tissue pocket, place it on the right side of the spine, and finally, after you ligate the middle sacral vessels, place the gold bifurcation blade. Each blade that begins as a handheld blade now becomes a rigid self-retained retractor system by using these mini arms. So these mini arms are designed to first, just with finger tightening, lock to each separate retractor blade. They're secured with these black-handled wrenches. And then finally, this wing nut is locked, which locks everything rigidly. The beauty of this is it's easy to loosen that wing nut and swiftly readjust any of those retractor blades that you need to individually or all of them. So this is just a intraoperative image of what you just saw from an RS diagram looking at L5S1, where you see the blue blade. Here's the pin placed into the sacrum, always distal at L5S1. When we move proximal to L5S1, the pin that's used is always in the cephalad blade, the blade that moves away from L5S1. And you'll see there's a light source that goes in here that really allows you to shower this surgical field with photons, giving you outstanding visualization of the spine. And here you see the gold bifurcation blade protecting the bifurcation so that if you want to place a plate here on L5 S1, you can. This is the mini arm that you saw at the artist rendering. You always attach the mini arm to the retractor blades first, here and here. And then this remains flexible. Do your final blade positioning and then lock the wing nut that makes this arm rigid. In this situation, you see that the 3 orange handheld blades have been removed. It just gives the surgeon and your fluoroscopist, your fluorotech, more room to work around the surgical field. And in this case, because these blades are radiolucent, you really get outstanding access for a good lateral view and a good AP view at L5-S1. Now, as we work cephalad L5-S1, you're going to use a 2-blade approach. And you certainly can use a 3-blade or a 4-blade approach, but as you become more and more skillful at this, you're going to need less exposure. So once you identify your target disc and you're on your disc, yeah, I think you'll find a 2-blade approach to this satisfactory. In this case, you see I'm using this is the gold blade instead of the blue blade, just because we didn't need the blue. You can use the blue blade here as well. It's wider, or the gold blade is more narrow. And as your skin incision becomes smaller, you're going to find that you're going to be using this more narrow blade more often. The threaded pin is placed cephalad, and once you retract that psoas back, you're going to see a good 3.5 to 3 centimeters of disc space here, all the way to the anterior longitudinal ligament. This Homan-tipped blade, or the black blade, excuse me, we place this with the exact same technique we used at L5-S1, using a combination of either a pool suction tip and endo-Kittner, or the endo-Kittner along with the tip of this black blade to create a soft tissue pocket into the spine, staying immediately on the anterior spine and placing this blade in this position. Now, this blade has a radius of curvature to it that makes it very difficult for the blade to go too far anterior or too far to the other side of the spine. And when it's hinged back against the soft tissue, it wedges in here nicely so that you can work from an oblique approach into the L4-5 disc or L3-4, L2-3. The way we avoid injury to these vessels, the segmental vessels, is palpate with your finger. Always feel for the ridge that represents the disc. And in this case, it's going to feel very similar to you as to doing an anterior cervical discectomy and interbody fusion. So feel for that ridge, and then you'll know you're on the disc space. To identify the disc space with certainty, there is a Penfield elevator, a long Penfield elevator in the Camber system that you can place on the disc and get a lateral fluoroscopic image to ensure that you are at the correct disc or your target disc. And here's just a cadaveric specimen looking at the space between the great vessels and the psoas muscle, outlining here with my cursor. And you can see that when you're working into the psoas muscle, we're not destroying the psoas muscle like we do when we do direct lateral surgery. When we do direct lateral surgery, we go bluntly through the psoas muscle, but we really tear that muscle up a fair amount. When we work anterior to the psoas, we preserve a lot of the psoas integrity. Now, we still get under the psoas, we retract it posteriorly to make sure that we can see our target disc well and get into it. Here, the great vessels from L5 up, we're doing very, very little mobilization of the soft tissue anterior to the spine. Once you create that small soft tissue pocket with the tip of that black Homan blade, you're going to place that Homan tip into that little pocket anterior to the ALL, and there's no more mobilization of the great vessels after that. If you inadvertently get into the space between the discs and have a segmental bleed, the way to address it, take a sponge stick, place it on the vessel, staunch your bleeding, get your bipolar Bovie electrocautery, and get onto that with your bipolar to halt the bleeding at the segmental vessels. But typically, the goal here with this procedure is to preserve, as you can see a pair of them right here, is to preserve these segmental vessels. And here, once more, is the corridor that we're looking for. Here are the great vessels. And here with my cursor, if you follow, is the psoas muscle. This is the window this is going to be your working window to get into the disc space from an oblique approach. And here, just again, going back to skin markings, it is just so critical that every disc that you're going to remove and replace and to fuse, you want to mark on the skin both the anterior disc, posterior disc that represents the anterior margin of the spinal canal, and then the trajectory of the disc. So here's an example of the variant retractor access system being used above L5S1. In this case, you see that the L5S1 disc has already been removed, replaced, and fused through this access site. And then using the same skin incision, the same incision in the abdominal fascia, we move up and do another blunt muscular dissection over the L4-5 disc to work at this level. Again, two retractor technique. Here's the gold retractor retracting the psoas muscle. The pin is placed cephalad, so it's away from the iliolumbar vein. Remember, there's going to be an iliolumbar vein at L4-5 moving over the L5 vertebral body. That's why we never pin into the L5 vertebral body. Just make a general rule, pin cephalad when you're north of L5S1, pin caudad or distally at the L5S1 level. Now, in order to effectively perform a discectomy, posterior decompression, end plate preparation, and then distraction with implant placement, you're going to require specific tools designed for the oblique approach to the lumbar spine. And Camber has an entire host of those available to you that are, I can introduce them to you here, but they're better. You'll learn more about them actually holding them in your hand. So you just have to find your Camber representative, get plugged into them, and get these instruments in your hand. But they all have a 25 to 30 degree angle, 60 millimeters from the tip of the working portion of the tool. This allows you to get into the disc space. And once you're in the disc space, you're going to feel you have all the advantages of an open ALIF, as well as all the advantages of a direct lateral interbody fusion. And so you're going to use these tools, particularly. So for example, this OLIF cob is designed to go across the disc space, undercutting the subchondral cartilage along the end plate, and then cutting the annular fibers on the far side, which at L4-5 and north are critical to mobilizing those disc spaces in order to get the reduction in anatomy that you're working to achieve. At the L5S1 level, the tools you're going to use are very similar to traditional supine ALIF tools. So your straight cobs, straight curettes. So the tools you use at L5S1 are going to be very familiar to you because they're almost identical to traditional supine ALIF tools. The one difference being you're going to need an inserter that allows you to place these spiral implants in an off-axis fashion to get them into first L5S1, and then there's a specific inserter for the implant placement above L5. And this artist rendering just shows you how effective these tools can be. So here's your oblique approach to L4-5. And you can see how with this cob, it allows you to move into your access window, work across the disc space, and get through the far side to ensure that you've transected those annular fibers on the far side, maintaining the ALL. If you wish, you can take the ALL down if you have a need to create a hyperlordotic situation to establish the sagittal lordosis that you need. However, with the ALL intact, which is something we can do here that you cannot do with a traditional supine ALIF, with the ALL intact, once you place your appropriately sized interbody implant, you can really get good posterior disc space distraction, which allows for outstanding resolution of the foraminal stenosis and central stenosis. So, and again, here's just another in these series of OLIF instruments available to you, a box cutter that's set to work from an oblique approach, a cob that you've already seen, curettes, and then stirrup ring curettes to move across the disc space from an oblique approach. So I hope that's been helpful to you. that concludes what I'm going to talk with you about early on. We'll have a question and answer session in a moment, but I'm going to turn the remainder of the didactic portion of the talk over to Dr. Jeffrey Mcconnell, and he's going to talk to you a little bit about the bioscience behind the nanosurface metal technology that we're using and how the arch technology was developed to be used in the interbody space. So thank you very much for your time.
Good evening. We'll start with the second polling question. We'll ask the audience, what are your biggest concerns when considering the adoption of the OLIF into your practice? The approach, managing complications, or patient selection? So if everybody can answer that question, we'll hopefully get a quick response. All right, so it looks like everybody's answered that. Yeah, and I think this is a very common response that we get from many of the participants in the labs that we do. And yeah, it seems that the biggest concerns have to do with the approach itself, and then managing any potential complications. So with that, we'll answer those questions hopefully in the Q&A session. Thank you, John. And it's a pleasure to be here and share the Camber SPIRA technology with you. So this presentation, we're just going to go over the technology itself and why the SPIRA cage is so much different than what's out there today for use in interbody fusion. So to Camber's credit, they've done an amazing job of designing an implant that's really optimal for interbody fusion. The SPIRA technology has an arch design, which just like a Roman arch, or it stood the test of time for the distribution of load with minimal footprint. But these multiple arches in the SPIRA cage will distribute the forces evenly across the end plate, and it's distributed over about 40 different points of these arches. The cage itself is 3D printed, and its surface is such that it's optimal for encouraging bone cell proliferation and growth with time. So the titanium itself, we know, is very orthopedic friendly or bone friendly. The osteoblasts like a titanium surface. Titanium itself will encourage or attract osteoblasts to the surface. And when the surface itself is optimized with the pore size, it's going to be even more osteopromotive and encourage bone ingrowth and on-growth to it. And the way that the SPIRA cage surface is designed at the nano level, the microenvironment level, it can encourage osteoblast proliferation and bone growth within 3 days. And you can see these slides here at the bottom on the right, after 3 days and after 7 days, the amount of osteoblast proliferation that's happening. So it's a very novel bony surface, again, for osteoinduction. And the roughened surface itself also provides an immediate stability when you insert the cage. So that roughened surface provides a lot of friction, which then holds the cage in place. Unlike some other very common interbody implants with peak surfaces, it can be somewhat slippery, and you don't really get that friction fit in place. So this material, this surface technology, really promotes a mechanical fusion, if you will, just after you insert it. So the SPIRA line of cages provide different designs. So depends on exactly how you would like to approach the inner space, and that does depend on the level. So the more proximal we are in the spine, the more likely we're to be in the oblique plane, or even in the lateral plane. We have the cages to be able to do that. So there's a SPIRA L, which allows the cage to be inserted from a direct lateral approach for anterior to psoas, and then we have the SPIRA O, which is really I think a step above anything out there today that is used for the OLIF procedure, because it really optimizes the OLIF approach. So it allows us to take advantage of that anatomic corridor, which the OLIF is being used for. And then there's the SPIRA A, which allows you to insert the device from a direct anterior or anterior lateral approach. There's two places that you can mount the inserter on that particular cage, which allows basically two different insertion angles. As I mentioned, the SPIRA O is designed specifically for OLIF. It's really a game changer for this particular surgery. So working anterior to the psoas, just minimal retraction of the psoas muscle to provide an adequate window. The SPIRA O is meant to insert at about a 25-degree angle between, and best used between L2 and L5. At the L5-S1 level, we're going to be usually using a SPIRA A, and there's also an inserter which is adjustable, which helps facilitate the OLIF procedure at L5-S1 to allow us to insert that cage to at least get it started, and then we can change the angle and come more directly anteriorly with that cage. So the beauty of the whole OLIF approach over some of the competition that is in the space of OLIF is the fact that we don't have to perform a orthogonal maneuver. So the implants and the instruments are all designed to be inserted at that optimal 25-degree angle, instead of having to have a bigger incision and push your hand directly anteriorly and try and insert a cage directly from lateral in the OLIF space. So we'll just highlight a few cases just to show you the different cages, whether it's a SPIRA O or SPIRA A, on how they're applied in these situations. So this is a 47-year-old gentleman who'd had a prior L1 to S1 decompression for spinal stenosis. And he did well initially, had relief of his neurogenic claudication. However, he developed recurrent back and bilateral leg pain. And this MRI scan lateral shows you why that's happened. He's now developed a herniated disc at L3-4. He's a rather large gentleman. He's 316 pounds. His BMI is 41. He's just a really solid, big guy. A lot of tissue in the back there to get to the spine. So there's obviously a couple of ways you could go about tackling this case. Here's the axial image at L3-4, and you can see the problem. He's got this big diffuse disc protrusion, which is occluding the canal, in addition to some additional facet hypertrophy. And his plain X-rays shows that he's got a spondylolisthesis at L3-4. And then you can see on the AP here his previous decompressions at multiple levels. So obviously, this is something that many surgeons would approach from a revision posterior approach with doing additional decompression and then a T-lift to stabilize this. But I think this is an ideal situation for the OLIF procedure in a revision situation. And what we're trying to do is we're trying to restore disc height, which decompresses the foramen, and also by realigning those vertebrae and distracting the inner space, we're gonna get rid of we're gonna open up the spinal canal and do an indirect decompression. And that guy looks like he was pretty stenotic there. There, many of us wouldn't think that we'd be able to achieve enough decompression indirectly, but this is a really powerful technique, and you have to take it on faith that you're going to get indirect decompression. And so that's what we did in this case. This is a SPIRA O implant inserted at that 25-degree angle anterior to the psoas with a minimal corridor. And this is about the least invasive way that I could think of doing this surgery. And of course, the screws were then placed percutaneously to stabilize it. And complete relief of his recurrent leg pain symptoms, and he's done very well with this procedure. This is a second example. This is a 67-year-old female. She's had low back pain, and she has bilateral buttock and leg pain consistent with neurogenic claudication with standing and ambulation. And you can see her x-rays here. She's got a collapsed disc at L4-5 with a degenerative spondylolisthesis. And this is her MRI scan, and you can see the stenosis here and the thickened ligamentum flavum. And you can see that the corridor that we're going to be working in here is anterior to the psoas from a left side approach. And again, for me, this is a great indication for an OLIF procedure. We can restore disc height. We can reduce the translation. And by distracting the interspace, we get good indirect decompression at the L4-5 level. And here are those post-op x-rays. You can see preoperatively the amount of listhesis. And with percutaneous screws, we're able to anatomically reduce that spondylolisthesis, which again, by realigning the canal, we get that much more additional indirect decompression. A third case, this is a 65-year-old female. She's a urology OR nurse. She's had low back pain, bilateral lower extremity pain. She had prior L4-5 and L5-S1 laminectomies and discectomies. She was significantly osteoporotic, and shortly after considering her for surgery, she developed an L1 and L2 compression fracture, and had a previous right hip fracture in the past. So I made a decision that we would delay her surgery and actually pre-treated her with Forteo to strengthen her bones for about 6 to 8 months. And then we went ahead and proceeded with the surgery. She's not a small lady. These are difficult cases to do from a posterior approach. I thought she would be a excellent candidate to consider OLIF. Here you can see the MRI scan at the L4-5 level. The corridor that we'll be working in is pretty nice here. The vessels are situated nicely off to the right side. We've got a nice window we can work with anterior to the psoas with minimal retraction on the psoas. And then L5-S1, the very forgiving corridor here. The vein is just on the left of the midline, but we should have plenty of space there to be able to do that from that approach. So here's the post-op X-rays. This is a SPIRA O implant inserted at the L4-5 level, and a SPIRA A implant with an adjustable insertion handle at the L5-S1 level. So initially, we adjust the handle on the adjustable inserter to get the cage started, and then as we get it started, we're able to adjust that so it's a little bit more directly anteriorly to get the appropriate vector for inserting that cage from a more direct anterior pass. So and then everything is locked down with percutaneous screws and rods. And she had excellent relief of her preoperative leg pain and back pain. So that's it for the case studies. Just a couple examples to show you how the OLIF technique and the SPIRA technology can be applied to different situations. All the faculty here tonight would encourage everyone to take advantage of the further educational opportunities that Camber has to offer. They are offering the OLIF BioSkills Lab. It's a combination of didactic and cadaveric training, so it's a great place to get a hands-on experience using the SPIRA technology and all of the instruments that are specifically designed for this approach and for the SPIRA technology. You got a great faculty at these meetings, and you can interact and ask questions. And again, I can't understress the importance of the hands-on aspect of these labs. And it's just a great opportunity for learning. So there are a couple of labs coming up, one in Austin, Texas on September 18th and one in Miami, Florida on November 6th. So look for that, and hope to see you at one of the BioSkills labs. We're also offering preceptorships as well. So if you want to come to one of our sites with either myself or Dr. Williams or Dr. Pelosa, we would be happy to host you for a live case. We can get you in there and see how this is all done in different situations. So hope to see you at one of these preceptorships as well. So you can ask your rep or the Camber representatives about these opportunities. So with that, I'll get this back to Robin, and we're going to go for a Q&A session.
Thank you very much. Dr. Williams, Dr. Abdullah, if you guys would kick it off, and we'll start with the questions from the audience. And looks like we may have one or two.
I don't see the questions yet, but I'll ask a question to Dr. Mcconnell. Jeff, you've done as many, or probably more of these than most people in the country. Is this your go-to revision surgery option right now? Or when is there a time, I guess, that you'd look at a case, revision case, flat back, degenerative problem, and you'd say, okay, the OLIF is not the right tool for that problem? But when would you say, okay, I've got to find a different tool in my toolbox than OLIF?
Well, thanks for that question. Yeah, I really, and we just did a revision case just this week. Patient had a prior couple of surgeries, an L4-5 fusion with instrumentation, and did this in the right lateral decubitus position. Put screws first, or actually you had to remove prior instrumentation in the lateral position and then put additional screws in, and then re-instrumentation. And of course, patient had severe collapse of the L3-4 disc and was really kind of stuck in kyphosis. So this is a really powerful tool. It is my go-to for these kinds of revision surgeries because I know I can effectively restore lordosis. And in this case, because he had prior fusion in somewhat of a kyphotic position, I was able to get hyperlordosis at the L3-4 level and overall restore a better lordosis of the lumbar spine. So again, in many situations, this has really been my go-to situation. One of the worst things is to try and do these things through an inner body from a posterior approach if they've got a lot of scar tissue and have had previous decompression. It's just, I hate CSF, and I'm never as happy with restoring lordosis as I can with an OLIF.
I agree with that answer. Of course, I'm a kindred spirit, and it's very rare that I would say this is not a sorry, okay, I'm going to kill this thing. It's very rare that there's not a time that I could not do an OLIF, even though I do continue to do traditional ALIFs and transpsoas procedures on occasion, just based on the patient body habitus, patient anatomy, and my needs in terms of intercolumn reconstruction. Dr. Pelosa, same question to you. What do you think? When would you be in a situation where you'd say, oh, there may be a preferable procedure to the OLIF when you have to tackle an intercolumn problem?
Well, I think you should be able to do all of the procedures so you're versatile enough. I think sometimes an ALIF at 5'1" is just a really easy operation. And particularly if there's a lot of disc space collapse, osteophytes, and no real good back for the vessel. So the ALIF is a really nice, easy operation, and you can do it with integrated screw implants or plates, and you don't have to go posteriorly, particularly if there's a lot of decreased disc height. So that's one thing. Also up higher in the spine, say at L2-3 and sometimes 1-2, a more lateral approach is better. Just do a little tiny river section and you go right lateral, and it's really fast, and it's just as effective as in terms of releasing the anterior column and restoring lordosis and getting a very good implant across. Sometimes in the higher part of the lumbar spine, the ribs are lower and they get in the way and they're harder to deal with. So it's easier to go just do a very small rib resection and put a small one of the retractors in, and you've got your exposure there. But the OLIF has now been more of a mainstay for me to do an anterior release, reconstructing lordosis and getting a very good implant in. And then I'm on my way. I think the posterior approaches, although a lot of our colleagues like them a lot, I think they're very limited when it comes to deformity, when you have to correct a significant deformity, particularly in the sagittally. I also think a coronal deformity is much easier corrected from an anterior or an OLIF or a lateral approach. So depending on the anatomy and depending on your confidence and also your resources, you need to choose the appropriate procedure. You need to be very facile with all of them, though, so you're not a one-trick pony.
Dr. Williams, we did have a couple questions here. I don't know if you can see them on the screen or not.
I can't, Robin. If you could read them to us, we'll tackle them. Go ahead.
Here's a question, actually 2 questions from James Cole. I'll read them both. First one is, insurance is making me do vasectomies in order to approve the ALIF. Are they making you do this even when it is not required? And then he asked a second question. Have any of you encountered scarring of the L4, 5, or L5S1 vessels that prevented you from proceeding with the surgery? I do a lot of ALIFs and OLIF D-lifts and frequently have L4, 5, and L5S1 vascular scarring that was easily dealt with the anterior approach, but I would think it would be more difficult to deal with in the OLIF approach.
Let's let Dr. Abdullah tackle that second question first, and because the coding question will be a short one. Dr. Abdullah, can you give your thoughts on revision surgery in the anterior spine setting?
Sure. I mean, for the L5S1, only in like transitional level anatomy, it is harder in OLIF than ALIF because you have more control how you dissect the vessels, because you have to really move the bifurcation high. If the bifurcation sits right on the L5S1 disc space, it becomes harder to do it in an OLIF approach, and obviously with osteophytes. But I think that because the gravity is helping you, it's actually easy to dissect, especially in the L4, L5 space in an OLIF approach than in the ALIF, and definitely is more forgiving because you're not pulling the weight of the entire abdomen when you're pulling down on the vessel. So for transitional anatomy and with osteophytes, I would prefer the ALIF approach, but otherwise, I think the OLIF is, at least from a ease of dissection standpoint, easier in 4-5 and in 5 and in many cases.
So Dr. Williams, I do have another question that came through. What training steps do you take to ensure successful adoption of the OLIF in your practice? And what training steps would you recommend?
The answer to that really depends on where you're at in your development as a spine surgeon. If you're fresh out of training and have limited anterior spine exposure, I think the right place to start is pairing with a company that can help you spend some time first in dry labs, then in cadaver labs, to train in this exposure. I tell you, Camber for me has been unbelievable to help me develop the skill. And I know they're committed to this as a part of their core principles. So if you reach out to Seth Anderson, to Brooks McAdam, and say, hey, I have a real interest in furthering my education in this arena, you'll find people that will help you do that. If you're already a person that is comfortable working in the anterior space, you know, maybe you're doing traditional supine A-lifts with an access surgeon, or maybe you're already done, you know, dozens of direct lateral trans-psoas procedures, and you're ready to just move your posture anterior to the psoas. That's a pretty straightforward thing to do, and the correct way to do that is basically just the way I outlined for guys straight out of training. Well, you know, get comfortable with the dry lab first, then get into a cadaver lab, and then do what Dr. Mcconnell suggested, and see if you can either get with Dr. Pelosa, Dr. Mcconnell, or myself, and get in a situation where you can scrub in surgery and be able to put your hands in the patient and palpate the vessels into the psoas to stay safe. Because safety, this procedure is all about what's best for the patient, and the minimal morbidity of this minimally invasive approach is fantastic, but you really want to be comfortable with the anatomy moving forward.
But for Dr. McConnell, there was a question that came up that I think goes, your case studies, I noticed that they had you had pretty high BMI patients, which was, I thought, really notable. But the question would be, what patients should surgeons avoid choosing for this procedure?
Well, the obvious ones are, I think, you know, anybody who's had some sort of extensive abdominal surgery or retroperitoneal surgeries of any kind, certainly any vascular surgeries, and maybe Dr. Abdullah can weigh in on this as well. You know, those patients who have really extensive atherosclerotic disease, you know, they got more calcium in their artery than they do in their bones. I'm a little bit hesitant if I know that I have to retract the vessels a bit more. The case that I had mentioned, the revision case that we just did this week, actually, the gentleman did have quite extensive atherosclerotic vascular disease, but the window to access at L3-4 is generally very forgiving, and I knew that I could access that quite easily without manipulating any of those vessels at all. So you have to pick and choose. You have to look at the corridors. BMI, I think, for me, this is you know, these are patients that I probably would have turned down for the more traditional surgeries and posterior surgeries because of their size. But with the ability to place percutaneous instrumentation, and we've been actually experimenting more and more with single position surgery with robotic assisted surgery. We can do this pretty accurately and with much less morbidity than what's traditionally done. So I've been kind of, I cringe every time I have someone with a very, very significant BMI, but you know, in some cases it's unrealistic to ask these patients to lose weight. So if it's a simple enough, you know, 1 or 2 level case, I have been taking them on, and then they do actually do very well, and they can often leave the hospital in a very short period of time. So, but there are some absolute contraindications, I believe. But again, you know, some of the you got to really know what the vasculature is, and anticipate what that's going to be. And I think that's some of the hesitation with a lot of the surgeons.
Just a follow-on comment to what Dr. McConnell said. It's fascinating how placing the patient in the lateral decubitus position makes them look smaller. When you get the anesthesiologist to apply a paralytic, relax the abdominal musculature, gravity just pulls that abdomen away, and it's remarkable how many people you can treat who otherwise would really go untreated. I mean, if you had to do a revision TLIF on a patient with a BMI of 45 or a traditional supine ALIF, you just basically tell them to come back after they'd lost 100 pounds. These patients that come in a wheelchair with the dynamic spondylolisthesis, maybe that came from their obesity, but are committed to getting better. You can really help them by learning this procedure, because it really does make them small. When their musculature is relaxed in a lateral decubitus position, it's amazing how quickly you can access L4-5 and L5-S1.
Let's do one more question. Let's see. We do have a couple, and whoever wants it. So the question is: do you approach 5-1 with ALIF or OLIF when not fusing L4, L5?
I think it's I think John Pelosa had mentioned this a bit earlier, that if it's a straight up L5-S1, I'm very used to doing that, and I can do it very, very quickly. And so if the patient is not too large, I can do an L5-S1 ALIF, and that is a very much a go-to for me. And actually Camber has some technology that allows us to do these interbody fusions without having to flip the patient and put in posterior instrumentation. So I do that a lot. But when I'm going to do an L4-5 and an L5-S1, I think the lateral position is a definite advantage.
Let's do one more question. This has been really a terrific course, and congratulations to Camber for just doing such a wonderful job all the way around, and then the follow-up with all the additional courses. The final question, it has to do with the access surgeon. Should the access surgeon see the patient before surgery, and what steps should be taken if an access surgeon is part of the team?
The access surgeon should be part of the team and should be involved in at least the preoperative planning. He should at least, or he or she should at least have seen the MRI scan, understand the vasculature, and understand the diagnosis and the goal of the surgery. Oftentimes, we may change the approach depending on what the access surgeon thinks, because if you're using an access surgeon, that surgeon is going to be responsible for moving the vessels and protecting them. So we like to do that. We involve them in the procedure, in the planning, and it works a lot better that way. I would say also that, going back to the previous question, the morbidity of the OLIF is much less than posterior or multi-level anteriors. If you're doing 2-3 level anterior exposures, that can be a significant procedure for the patient. And when you do just tiny, small little OLIF exposures, it really is helpful. So you need to know how to do all of them. I think a single level 5-1 is a nice thing for an ALIF, but if you're going to go front and back, particularly if you're going to do it simultaneously, then an OLIF's a really good option for it if all things are equal and the vessels are in good shape. But if we're doing more than one level, then I'm thinking more of a OLIF procedure to release the anterior. So, and going back to how do you train, I think you should have a lot of anterior lumbar experience before you even try to do this. And in our training and our experience and all that, we worked with anterior surgery almost, well, it wasn't exclusive. We still did TLIFs and PLIFs and stuff, but we were primarily anterior surgeons. And we did it with a lot of vascular access guys. And so we were really comfortable with the vessels. And if there was ever an injury, we would help the access surgeon to repair it. I don't know every access surgeon in the country, but I know a lot of them, and I don't know any of them who haven't had a vascular injury.
So this is something you need to have some experience with and comfort with, that you can deal with the injury or help your vascular surgeon. Or if you're having some doubts and you want to get more experience, and work with access surgeons until you feel that you can do it by yourself. And you should do simple cases first. Don't try to do a major deformity with 4 and 5 level anterior exposure. That is not the one to start with. Just a nice, easy degenerative, maybe 3, 4, 4, 5 is where you should start until you get some more experience. And then you should also have access to somebody if should something go wrong, and you should have the ability to take care of it.
Thank you all for participating this evening, and gentlemen, feel free to turn off your microphones. We're going to have a short video to wrap everything up. And again, congratulations to the whole faculty and Camber Spine for putting together really an amazing program.
Camber Spine is being very supportive with education for the OLIF procedure.
When we talk about, graduate level or advanced level education, this is not easy education to get. If you don't have an organization that comes up alongside an idea, you can't really deliver that idea.
As a young surgeon coming out of fellowship, you're always used to showing up to the OR and everything's ready to go well. You take that for granted, and then you start going into practice yourself, and you show up to the operating room for the first time and being asked by the anesthesiologist how you want this, the nurse is asking you questions, the tech is asking you questions. So then you start figuring out, well, I don't have those tools I had in fellowship that my attendings used. Like, what do I need now? Camber is able to quickly respond to my needs. If I say, hey, could you really use this retractor next time, or I need this cob next time, I'll have it by the next case.
You can go sit in lecture halls and see the greatest world-renowned surgeons just sit up on the podium, but it's just a different experience what Camber is able to provide us.
These labs are really a great opportunity for the participants to learn the OLIF procedure. We can emphasize the nuances of the technique to make it successful for them.
I've been doing this 20 years, 500 neck and back surgeries a year, why change? But if it's better for the patient and you are willing to get sweaty palms and step outside your comfort box, it makes it so much easier when you have Camber, Dr. Williams, and Dr. Mcconnell. You have this support around you, makes it so much easier.
Even though I'm one of the faculty in the course, I'm always learning something. You learn something from the participants, you learn something from the other faculty, how to do it better. This is just it's an easier, safer way of doing it, which is always better for the patient and better for us.